I would like to welcome everyone to the 2024 AAN Annual Meeting Top Science Press Conference. The American Academy of Neurology is the world's largest association of neurologists and neuroscience professionals with over 40,000 members. This year, the meeting is being held in Denver and online April 13th through the 18th, with more than 13,000 attendees from around the world. My name is Renee Tessman, and I will be your host. At this year's meeting, more than 2,600 scientific abstracts are being presented by researchers sharing the latest scientific advances in brain disease. You will hear about 3 of those abstracts today. Thank you, members of the press, for joining us. Today, Dr. Paul George will present his choices for top science. Dr. George serves on the faculty at Stanford University as a vascular neurologist in the Department of Neurology and Neurological Sciences. He is a physician scientist focused on caring for neurology patients and improving neural recovery therapies. As faculty, he helped create a multidisciplinary stroke recovery clinic at Stanford. Dr. George is chair of the American Academy of Neurology Science Committee, and it is the Science Committee that oversees the selection of the science being presented at the AAN annual meeting. Dr. George will be joined by 3 authors of abstracts that he has selected to feature at today's press conference. Dr. Masoom Desai of the University of New Mexico in Albuquerque, Dr. Charles Chu of the University of California, San Francisco, and Dr. Prashanth Rajarajan of Mass General Brigham in Boston. After each presents their abstract, Dr. George will ask the authors a few questions. We will then take questions from journalists via the Q&A function. Again, to ask a question, post your name and news outlet in the Q&A, and if called upon, we will ask you to unmute yourself and ask your question. Use chat only if you're having technical issues. I would now like to introduce Dr. Paul George, who will share some opening remarks about this year's AAN annual meeting, as well as about his selections for top science. Welcome, Dr. George.
Thank you, Renee. And on behalf of the Science Committee and the American Academy of Neurology, it's my pleasure to welcome you to the Top Science Press Conference today. It's really the opening act of the scientific programming for the AAN annual meeting in Denver, and I'm really excited about some of the groundbreaking science that will be at the meeting this year. This science includes research from the leaders in the field across our plenary session and from our invited speakers, as well as some fascinating science discussing the latest in neurologic advances presented in over 350 platform presentations and over 2,100 posters. It's going to be an amazing meeting, and so I'm excited to see everyone in Denver in just a few days. In what has become kind of a tradition for these top science press conferences, there's often been a theme, and so I thought for this year's group of abstracts, the theme of advancing the limits of neurologic care was a great theme. Each of these abstracts represents innovative methods of using new technologies or experiences to improve our understanding of neurologic conditions, whether it's using next-generation sequencing and new testing paradigms to better identify disease pathogens, or using cross-disciplinary studies to evaluate how medical treatments affect neurologic diseases, to exploring how machine learning and AI can improve neurologic care. All of these studies represent insightful ways to advance our field and to improve the care we are able to provide to our patients. So I'm excited to hear from the authors and to dive into their breaking science today.
Thank you so much, Dr. George. I would now like to introduce Dr. George's first guest, Dr. Masoom Desai of the University of New Mexico in Albuquerque. Dr. Desai, please turn on your video and audio. Dr. Desai will present her abstract titled Impact of Automated Seizure Burden Measurements on Functional Outcomes, Sub-Analysis of Safer EEG Trial. Dr. Desai has no disclosures. Please note this abstract is emerging science and embargoed until 4 p.m. Eastern Time, Thursday, April 11th. Please do not publish stories on this research until the embargo lifts. Welcome, Dr. Desai. Please share with us a summary of the findings of your research.
Thank you, Ms. Tessman and Dr. George, for giving me this opportunity. I'm Masoom Desai, neurointensivist and neurophysiologist at the University of New Mexico, and it's my pleasure to be here and present our stimulating study results. Several decades of research highlighted the significant correlation between seizure burden and unfavorable outcomes in patients with various neurologic conditions, both in adult and pediatric population. The traditional method of manually interpreting EEGs to identify seizures and their associated burden is a complex and time-consuming process that can be subject to human error and variability. Our study addresses the critical need for automation in monitoring epileptiform activity and seizure burden. In our study, we explored the impact of automated seizure burden measurements on functional outcomes in critically ill patients. This study is a sub-analysis of SAFER EEG trial, which focused on point-of-care EEG, a rapid access reduced montage EEG system that, when paired with an automated machine learning tool, Clarity algorithm, provides a novel approach to monitoring and analyzing seizure burden in real time. Our hypothesis posited that higher seizure burden, as determined by an automated machine learning algorithm, would correlate with unfavorable patient outcomes. Utilizing data from 344 point-of-care EEGs across 4 academic sites, we excluded those without Clarity data or necessary clinical outcome scores, focusing on a cohort of patients aged 18 or above. This methodology allowed for a comprehensive analysis of seizure burden's impact on clinical outcomes at discharge for patients, specifically looking at modified ranking score of 4 or greater and discharge to long-term care facilities as indicators of unfavorable outcome. The results were compelling. Before adjusting for clinical covariates, we found a significant association between high seizure burden and unfavorable outcomes. Specifically, 76% of patients with a seizure burden of 50 or higher had unfavorable modified ranking scale outcomes at discharge, and a similar proportion was discharged to long-term care facilities. After adjusting for relevant clinical covariates, patients with a high seizure burden exhibited a 4-fold increase in odds of unfavorable modified ranking scale outcomes at discharge compared to those with 0 seizure burden. Moreover, seizure burden present in the last quarter of the recording was particularly indicative of unfavorable outcomes, suggesting the critical timing of seizures and its impact on patient prognosis. This study marks the first to demonstrate the association between high seizure burden as derived from an automated AI algorithm, which is now FDA approved and commercially available, and clinical functional outcomes at discharge. By providing real-time, accurate assessments of seizure burden, these tools can guide more effective strategy treatments for patients, potentially mitigating some of the adverse effects of prolonged seizure activity on patient outcomes. The implications of our research are profound, indicating a pivotal shift towards integrating AI and machine learning guided automated interpretation in management of critically ill patients with seizures. As we move forward, our research will concentrate on applying this advanced tool in clinical decision-making and clinical practice, examining how it can steer treatment decisions for patients. We'll also explore how this AI-driven approach influences clinical practices and assess its impact on managing seizure intensity and frequency, with the ultimate goal of enhancing patient care and improving outcomes for those affected by these neurological challenges. This not only represents a significant step towards personalized and precision medicine and patient care, but also underscores the value of combining forces with industry leaders and academic institutions, such as our team and Cerebral. And such collaborations are key to driving forward the intersection of technology and healthcare, promising a future where patient outcomes can be improved with the aid of cutting-edge tools. Thanks again for giving me this opportunity.
Thanks so much, Dr. Desai. Really interesting work, and I think just introduces this concept and it's getting more and more prevalent as we move forward here. One question I had, with these machine learning algorithms, AI, what you put in or set as parameters really affects the outputs. And so, I was wondering, as you were designing this study, the thresholds for high burden of seizure, how you came about designing some of these parameters or thresholds that you used for the machine learning algorithms.
Yeah, so the algorithm was derived from 50 different EEG features, and so it incorporates a comprehensive list of EEG features that have been associated with outcomes in patients. And it analyzes EEG activity every 10 seconds from all EEG channels on that limited montage EEG. And it gives us the seizure burden in the last 5 minutes for the patient. And so the higher the seizure burden, the more time the patient has spent in seizure activity.
Great. And as I'm sure you're aware, AI seems to be everywhere these days. And you mentioned towards the end a little bit of maybe how we can start to incorporate this into our practice. But how do you envision in epilepsy in particular the partnership between a physician and using AI as a tool or otherwise?
Yeah, I think this is a great opportunity to advance the field forwards. The way I see this field evolving is from the time that we started applying limited montage EEG into the clinical setting back in 2018, 2019, where we know from the DECIDE trial that it did influence decision-making at bedside for clinicians as well as patients. And I think now the next step for us would be to prospectively analyze what is the potential for a machine learning algorithm to guide clinical decision-making and perhaps come up with an algorithmic approach how to treat these patients. And so it calls for utilizing this in clinical setting where we can standardize management for patients based on objective data that can be provided by an AI-guided tool.
Great. And so along those lines, do you ever envision, a scenario where maybe in hospitals where there's not a epileptologist available or neurocritical care physician, where AI decision-making would really guide the physicians taking care of the patients?
Yeah, absolutely. I think that from all the data that we have across United States, and more so in certain parts of United States, we know that we are at shortage of neurologists and that expertise that is needed in interpreting EEGs. We're inundated with high amount of volume studies that are being performed on patients, on many different patients with very different pathologies. And also one of the advantages of AI is that we are able to overcome that subjectivity in interpretation and be able to provide timely interpretation and access to the study results that are important for clinical decision-making. And so there's a lot of data now of using this tool in community-based setting, low resource setting, and how that can influence the time to treatment, the time to obtaining EEGs, and also impact on patient outcomes. I think that we would also want to look at using specifically this machine learning algorithm in those settings and see if that impacts it, but we do have data on using limited montage EEG in those settings. And so I think the next step forward would be to look at how the machine learning algorithms can be applied in those hospital settings.
Great. I think now we'll open it up to the media portion.
Thank you, Dr. George. Yes, we do have a question from Megan Brooks of Medscape. Megan, would you like to unmute yourself and ask your question?
Sure. Can you hear me?
Yes.
Oh, thank you. So, Dr. George, I was just hoping you could maybe weigh in on what impact you think this could have and what need it might fill in the clinic, as a practicing neurologist, what the potential could be.
Yeah, and I'll have Dr. Desai weigh in as well. I think it's really exciting. I think it's early in the kind of the field of using AI to guide decision-making. I think having more information, as Dr. Desai said, that the machine learning algorithms can process and come to some output for is helps guide physicians as kind of another piece of information as they're helping to treat a patient. And then in some settings where there's maybe not as much clinical specialist, I think it's exciting to see as this unfolds where AI can guide, maybe the ED doctor or primary care physician as they're getting reads back from EEG or other things to help improve patient care. And Dr. Desai, feel free to comment as well.
Yeah, I think a lot of the applications for the limited montage EEG right now are in hospital setting. The question is interesting. How can we apply this in a clinical setting? So we know for seizure detection, there are different healthcare tools and technologies that patients are using now to detect seizures and gauge that seizure frequency. And so I think that could be a potential diversification of using limited montage EEG in that setting, given that one of the benefits that we have with that is the portability that comes along with using these tools. And so I think it is a potential arena that needs to be explored further.
Thank you.
Journalists, as a reminder, if you would like to ask a question, you can post your name and publication in the Q&A. And if we call on you, you will receive a notification to unmute yourself and ask your question. Your video will not be activated and the audio of your voice will be live. For those who have additional questions, seeing no more, if you still would like to put them in the Q&A after this presentation, please feel free. Dr. Desai will respond after the press conference. Dr. Desai, I do want to thank you for joining us today. As a reminder, Dr. Desai's abstract is embargoed until 4 p.m. Eastern Time, Thursday, April 11th, 2024. Thank you, Dr. Desai. We appreciate your presentation and joining us. We will now
Thank you so
move
much
on.
for having me here.
You're welcome. Thank you. We will now move on to the next presenter. I would now like to introduce Dr. George's second guest, Dr. Charles Chu of the University of California, San Francisco. Dr. Chu, you may turn on your video and audio. Dr. Chu will speak about his abstract titled Pathogen Detection and Associated Patient Characteristics from Clinical Metagenomic Next Generation Sequencing Testing for Neurological Infections. Dr. Chu has disclosures which can be found on AAN.com, and he is a founder of the biotechnology company behind this research. You may reach out to the AAN PR team for a link to his disclosures. The abstract is no longer embargoed. Dr. Chu, welcome. Please share with us a summary of your findings.
Thank you. And I would like to thank Dr. George, Ms. Tessman, and AAN for the opportunity to speak with you today. I am a professor in laboratory medicine and infectious diseases at University of California, San Francisco. I'm also the director of the UCSF Clinical Microbiology Laboratory. I'll be talking with you today about the use of metagenomic next generation sequencing, which is abbreviated MNGS, of spinal fluid for diagnosis of central nervous system infections. The general idea is by sequencing all of the DNA and RNA in clinical samples, in principle, we can diagnose nearly any kind of infection, whether it's caused by viruses, bacteria, fungi, or parasites. At UCSF, we have actually been running clinical MNGS assays over the past 7 years from spinal fluid to diagnose central nervous system infections in patients who have inflammation of the brain, meninges, or spinal cord. In this abstract, we report the longitudinal real-life performance of spinal fluid MNGS testing for diagnosis of infections from 4,828 samples collected over 7 years from 2016 to 2023 from patients across the United States and internationally. We detected a microorganism by CSF MNGS in approximately 17% of patients, including roughly 2/3 viruses, 20% bacterial, 10% fungal, and 3% parasitic. We also detected several novel and/or emerging pathogens that do cause central nervous system infections, including the cause of a fungal meningitis outbreak associated with surgical procedures in Matamoros, Mexico. To compare the performance of spinal fluid MNGS testing versus other diagnostic tests that we commonly perform in the hospital, patient chart review was conducted for a subset of patients seen at UC San Francisco, which was approximately 1,000 or 20% of the patients for whom clinical metadata were available. We combined the results of independent clinical adjudication from 3 different physicians, infectious disease and physicians and neurologists, and all available microbiologic tests to show that as a single test, the spinal fluid MNGS has an overall sensitivity of 63%, specificity of 99%, and accuracy of 90%. As a single diagnostic test modality, CSF metagenomic MNGS testing was more sensitive than all direct detection testing from spinal fluid combined, including antigen culture and PCR testing of spinal fluid, all direct detection testing performed on samples other than CSF, such as brain biopsy and blood, and indirect serologic testing looking for antibodies. The sensitivity for each of these other 3 modalities ranged from 15 to 46%, and all of these comparisons were statistically significant. If considering only diagnoses made by direct detection testing of spinal fluid for more of an apples-to-apples comparison, the sensitivity and specificity of MNGS testing of spinal fluid increases to 86% and 99.5% respectively. We conclude that these results justify the incorporation of CSF MNGS testing as part of the routine diagnostic workup in hospitalized patients who present with potential central nervous system infection. Thank you.
Thank you, Dr. Chu, and congratulations on such a study in over 7 years with all these patients. That's quite an amazing accomplishment. I was really fascinated the difference when comparing to kind of our usual CSF studies like white count and things like that, and the number of pathogens you found when the CSF counts weren't totally abnormal. Could you comment just on maybe why that is, or how the technique recognizes these things where some of our regular tests don't?
Yeah, I mean, it's a great question. One thing I should highlight is that, as you're well aware, it's very difficult to diagnose these infections. In fact, roughly about 50% of patients who present with presumed central nervous system infection actually end up without a diagnosis. And part of the reason may also be that these infections can mimic various non-infectious conditions, including, for instance, cancer or autoantibody syndrome or vasculitis. I mean, there are a number of non-infectious diseases that essentially mimic an infection. And clinically, as you've alluded to, these are relatively indistinguishable. It's very difficult on the basis of, say, the spinal fluid profile to actually be able to determine whether any given illness is infectious or not. And in addition to that, many of the tests that we commonly use for diagnosing infections, they're heavily targeted, meaning that you have to have some idea of what you're looking for in order to send off a targeted test to detect it. And spinal fluid as well is a very limiting sample. Typically, we don't get a lot of volume. And so we're unable practically from a volume perspective and sample availability perspective of actually, as well as a cost and turnaround time perspective of being able to send off every possible test for every possible organism. And so because of this is what makes MNGS particularly attractive, in that you could potentially have a test that can detect the hundreds of different pathogens that cause clinically indistinguishable infections.
Yeah, really interesting. I think you mentioned, about finding this pathogen in Mexico, but, these meningitis and encephalitis are really problematic around the world. And I always get a little nervous when you get too many syllables on your testing. It just seems to add complexity with metagenomic next generation, right? So what are you thinking about as far as simplifying this process so that it could be kind of a worldwide incorporation into our standard kind of neurologic workup?
Yeah, currently this type of testing is really confined to large specialized laboratories such as myself or reference laboratories. There are several commercial reference laboratories that have sort of developed this technique, but there's several disadvantages to having this solely a reference lab test. Namely, it's really the turnaround time. It's a time to send off the test to the reference lab to get results. That sampling and handling processing time can really delay the prediction of results. And I really believe that to see widespread use of this test, you really need to have routine clinical laboratories or hospital laboratories be able to implement this test. So much of my research has actually been focused on actually moving this test to portable instruments, for instance, or portable platforms, such as that you wouldn't need to have it run by like a specialized laboratory with bioinformatics expertise, and that it could be in the future run by routine clinical laboratories. And so this is sort of where I feel the direction of the field is moving. If you can really bring the technology to the point of care, directly to the hospital laboratory that's running the test, we can produce results that would have more actionable and more rapid impact on patients.
Great. Yeah, and one thing I was thinking is reviewing this science here. How do you envision, maybe next steps as far as using this to guide therapy or comparing it, head to head with kind of the traditional methods for therapeutic trials? What do you envision as far as next steps towards towards a trial like that?
Yeah, it's a great question because ultimately the purpose of the diagnostic test is to generate actionable information that could potentially guide therapy. One thing I should mention is that this at least the initial analysis was primarily focused on the diagnostic yield and the performance of this test relative to other diagnostic tests. We're actually currently working on a follow-up study where we're evaluating, again, from the same cohort of 1,000 patients for whom we have access to the medical chart. We're actually evaluating the what is the clinical impact in terms of, did it have, was there clinical utility to ordering the test? Did it have positive or negative, or, did not have any clinical impact on the management and treatment of the patient? And so those results, we're actually getting some very interesting results from that. And I think that having results or producing data like this will help us define kind of the role of this test in the future as part of the diagnostic paradigm. I believe in the long run, that's what's really needed are going to be prospective clinical trials done, clinical diagnostic trials similar to therapeutic trials, where you would want to evaluate this test head to head against other types of conventional testing to really be able to demonstrate that it has a clinical impact, or to define the populations, the patient populations or clinical use cases where this test would be most useful.
Wonderful. Yeah, so some exciting things to come as well.
Wonderful. Thank you, Dr. George and Dr. Chu. We will now take questions from journalists. To ask a question, post your name and news outlet in the Q&A. And if we call on you, please unmute yourself and ask your question. We have a question from David Levine. David, you may unmute yourself and ask your question.
And my question was about, I think these are all great. I'm just wondering, are insurance companies pushing back on some of these new ways to diagnose and use of artificial intelligence? I know that I had 1 or 2 medical tests this year, and they took great pride in telling me that they were going to use artificial intelligence, but one of them they had to send off and get permission from the insurance, and if they didn't get permission, I wouldn't do it, obviously, because it costs thousands of dollars. So that's my question, basically. How it's great you have all these wonderful things, just like you have new drugs like the weight loss drugs, but they're very, very expensive. I'm just wondering, what's the insurance on these things?
Yeah, that's a great question. It's a relatively complex question. One thing I should mention is that these tests are essentially laboratory developed tests in clinical laboratories. So they're essentially laboratory developed tests in CLIA labs, meaning that to my knowledge, there hasn't been a metagenomic next generation sequencing test that has been FDA approved. And I do think to some extent that this is going to be a necessary step, but there needs to be essentially FDA approval of a test such as this to establish a blueprint for reimbursement. But in addition to that, it's not only FDA approval or regulatory approval, but also that for insurance companies to actually pay for this test, very often they want clinical data. So it's basically they want evidence of clinical utility, and not only in terms of an impact on clinical outcomes in earlier diagnosis, but also in terms of a cost-benefit analysis to show, is it worth it to, admittedly a pretty expensive test, is it worth it to send off to do this type of testing? And so what I envision is that we're still rather early in the process. We're sort of like following on the heels of oncology testing, as you're well aware of, where essentially you are able to order and you do have FDA-approved tests, which cost several $1,000s. My feeling is that we would need to first demonstrate or have those studies that we alluded to that will really demonstrate that these tests will be cost effective and their specific clinical use cases. One thing I should mention also is that in our follow-up analysis that we are working on, for instance, also doing that sort of cost-benefit analysis in terms of the impact on costs. And we already know that patients with neurologic infections, central nervous system infections, are heavy cost burden in the hospital, as well as having high mortality and morbidity rates. Specifically for your question regarding insurance, this is primarily a test which has been developed as a test for hospitalized inpatients. And as a result, most hospitals that send off spinal fluid for this type of testing, it's essentially added to the patient's DRG or annual payment, insurance payment that's for their hospitalization to cover the cost of the hospitalization. So it's not treated as a separate test in that respect. And so we've had varying success with regards to getting, for instance, outpatient testing done and reimbursement. And for that really to be, for insurers to really pay for the cost of that test, my feeling is that there really needs to be, clinical utility data to justify the cost.
Thank you so much, David, for asking your question. Pauline Anderson from Medscape, you may go ahead and unmute yourself to ask your question.
Dr. Chu, you may have addressed this already, but it sounds like this is a research tool, and it sounds like it's very far away from clinical practice. Can you maybe speculate on how long it would take for this spinal fluid MNGS detection technology to be used in everyday practice?
Yeah, so Pauline, I have to clarify, this is not a research tool. I'm talking about a clinically validated test.
Okay.
So we've run over the past 7 years nearly 4,800 samples, and these are samples sent from hospitalized patients. The results were submitted as any other test that's done for spinal fluid clinical tests. The results were sent back to the hospital, and they were used to guide management and treatment of the patient. So I would like to clarify that this was not, it is a research study, although the actual test itself is a clinical test.
So would it be just used in hospitalized patients?
Well, primarily, roughly about 85% of the samples are in hospitalized patients, but there were also 15% of the samples were actually sent from outpatients. And in terms of reimbursement, as I said before, we would basically submit for, reimbursement, submit to insurance companies. Sometimes insurance companies would pay for it, and sometimes they would not. And really, there really needs to be kind of a more consistent, reimbursement scheme. As you know, this is, part of our medical system. But in general, this is a test. It is an expensive test, but it is a test that's being run clinically. It's not being run for the purposes of research.
How expensive is it?
That's a good question. I should mention that typically it is, in terms of the actual reagents, in terms of the actual cost of the test, I could probably run it. Maybe UCSF doesn't really want to tell me, doesn't want me to tell you this, but I mean, it probably costs roughly, around, anywhere from say $500 to $800. Now in practice, I mean, typically, the companies will charge, the more expensive to cover for overhead, et cetera. So, but I believe we currently charge roughly around $2,500 to $2,800 per test.
Thank you.
Wonderful. Thank you, journalists, for your questions today. For any additional questions, you may feel free to put them in the Q&A, and we will get them to Dr. Chu for his responses. Thank you, Dr. Chu, for joining us today. We will move on to the next presenter. Thank you. Our third guest is Dr. Prashanth Rajarajan of Mass General Brigham in Boston. Dr. Rajarajan, you may turn on your video and audio. Dr. Rajarajan will speak about his abstract titled Multi-Institutional Study of Neurologic Outcomes in People with Multiple Sclerosis who are treated with immune checkpoint inhibitors for oncologic indication. Dr. Rajarajan has no disclosures. The abstract is no longer embargoed. Hello, Dr. Rajarajan. Please share with us a summary of the findings of your research.
Great. Thank you so much, Ms. Tessman, and especially to Dr. George and the AAN for this exciting opportunity. Really thrilled to be sharing our work. I'll be talking to you today about the use of a new line of cancer treatment in patients with multiple sclerosis, or MS, which many are familiar with. That it's the most common autoimmune disorder affecting the central nervous system. And as you likely know, it's a disease that's characterized by relapsing and remitting course, featuring an array of neurologic symptoms due to inflammatory lesions in the brain and or the spinal cord. Now, what's great is that with increasing treatment options over the years for MS, patients with MS are living longer lives, and with age comes a higher incidence of cancer. These newer lines of treatment, like called immune checkpoint inhibitors, or ICIs, such as pembrolizumab or ipilimumab, they actually unlock the immune system's ability to attack the tumor and are being increasingly used through their efficacy in a variety of cancers, even as first-line treatment for some cancers. But they can also lead to the immune system attacking our own body, leading to what we call immune-related adverse events, or you can think of these as off-target toxicities that can affect a variety of tissues, including the brain and the nervous system. these off-target toxicities plus the theoretical risk of increased relapses or flares of pre-existing autoimmune disease make it a bit complicated for doctors to decide if starting a checkpoint inhibitor for patients with MS is actually the right choice. And this is made more complicated by the fact that the initial trials for checkpoint inhibitors excluded patients with MS, and there have not been any large studies really to determine the risk of relapse in this population. So with this as the background, we aim to bring together multiple institutions across the country to study patients with pre-existing MS that are treated with ICIs or checkpoint inhibitors to determine the rates of MS relapse or activity and other neurologic immune-related adverse events. And to that end, we performed chart reviews and identified 65 patients with neurologist diagnosed MS that were then started on an immune checkpoint inhibitor and were followed on average for up to a year from starting that treatment. The population tended to be older, so an average age of 66. And as is typical for older adults with MS, most were not experiencing relapses or getting disease-modifying treatment or active MS treatment. But our data reassuringly showed that only 2 out of the 65 patients experienced any new MS disease activity. One had a clinical relapse, symptoms plus a MRI lesion, and another only had minor MRI activity without any symptoms whatsoever. And the patient with the clinical relapse improved with a short course of steroids. Now, with respect to the non-MS related other neurotoxicities, apart from those 2, only 3 out of the 65 experienced these effects. And this included things like encephalitis or really severe neuropathy. And this, though, is in a similar rate to the general population as what's been reported in other clinical trials. So patients with MS are not enriched for or experiencing these adverse neurologic side effects in a higher rate than the general population. So taken together, our data really suggests that at least in older patients who tend to have less MS disease activity and higher rates of cancer, the diagnosis of MS should actually not preclude the use of immune checkpoint inhibitors, since it appears to be associated with a relatively low rate of MS relapses or disease activity and other neurologic adverse events, highlighting 2 things in our minds, which is that the high risk of cancer progression and the cancer-associated mortality outweighs the low risk of MS relapse in this population. It also highlights the need, I think, to determine the risk of relapse of other immune-related adverse events in the context of their pre-existing neuroimmune condition, as the risk varies probably by disease. And our study applies to MS only and not all autoimmune conditions, not all neuroimmunologic conditions, which each warrant further study in their own regard, including involving them in prospective studies moving forward, where this one was a retrospective study. But overall, our data are reassuring and can be used as evidence by oncologists and neurologists in getting patients with MS the treatment that they need. And that's our project. Thank you.
Yeah, thank you so much. I really liked how this study brings us out a little bit. You know, we've all gotten so specialized in medicine, and there's so many interactions, right? Patients don't just have single diseases. And so I think this is great to have more data on how our different treatments can affect things. It seems before your systematic approach here, there was some, concern that these immune checkpoint inhibitors may have more complication rates. What are some things that you may have been surprised by, or that kind of protected the MS patients, as age or other things that maybe reduce these rates?
Yeah, that's a great question. So yeah, the rates of relapse or autoimmune condition relapse or other adverse events really varied based on what autoimmune condition they had. And most of the data we have thus far really come from more systemic autoimmune disorders, so things like rheumatoid arthritis or Crohn's or psoriatic arthritis, polymyalgia rheumatica, things like that, which had a relatively high rate of minor but flares. In our particular population, I think, as you pointed out, I think one of the things is age that I think was quote unquote protective, and that there is this phenomenon, right, of immunosenescence as we grow older, and our immune system is a little bit less active, and this is mirrored by the fact that their autoimmune disease activity, at least in MS, tends to decrease with age. So I do think that this kind of baseline of reduced immune activation probably helps them. And the other is the type of treatment they're on probably also has some impact. So there are certain higher efficacy, newer MS treatments like natalizumab or the S1P inhibitors modulators that actually are associated with higher rates of rebound relapses if you stop them abruptly. So sometimes when patients get cancer, with patients that must get cancer, the provider is like, let's stop this treatment, let's start you on the cancer immunotherapy. But then when they get a relapse, is it because they stopped this, highly efficacious medication? Is it the checkpoint inhibitor? Is it both? Or is it primed already by this discontinuation? And that is a part of this question as well.
Yeah, I think it's complicated questions to kind of parse out. I think as you get all these medications involved and diseases. One thing along those lines is you start to narrow the population, right? MS patients, then MS patients on the ICIs. What did you learn, as you're designing studies, for this type of analysis or maybe orphan diseases? What are things that you might think of going forward, as you said, for kind of more prospective studies?
Yeah, I mean, the one is these are made a bit more difficult by the more you narrow, kind of the lower your N is, or your sample size, right? It's like harder to find that overlap of patients with MS that then get cancer that's treatable with a checkpoint inhibitor. And moving forward, I mean, some of the things we're looking into are, studying the cousins of MS, other neurologic diseases like neuromyelitis optica or MOGAD, the myelin-obstructive glycoprotein-associated disorders. But this gets even more difficult, right? Because these are even rarer, and then finding this overlap, smaller circles in the Venn diagram gets more and more tricky. But I think what we've learned so far, and what I think really depend on moving forward, is that depending on multi-institutional collaborations, this is actually thankfully brought together by medical providers for multiple sclerosis, an organization that kind of combines or brings together multiple providers across the country, and that allowed for this collaborative nature. And I think that this enriches us to allow us to find more of these patients, especially for trying to focus and home in on rarer disorders that may or may not be more aggressively autoimmune or have a proclivity for immune-related adverse events with certain treatments.
Yeah, one thing I was thinking of too, as reading your abstract here, are there different biomarkers or things you could do ahead of time to predict which patients might have a reaction to some of these other therapies? Or I know it was kind of a small number of patients in your study who did have a flare or things, but have you thought about, are there biomarkers you're excited to look into, or for future studies, so you can catch the patients ahead of time before you start the medication?
No, I think that's a great thought. I mean, you can certainly use certain clinical features, but in terms of what actual biomarkers we have, it's a little bit tricky with MS that has no specific antibody, but there's certainly markers of immunity or immune activity that we tend to use, at least at the initial diagnosis stage, that we might think about sampling CSF and just checking how those levels are doing. Similarly, in other related diseases like NMO or MOGAD, which do have their specific antibodies, it's an open question, but whether the titers of those antibodies and at the time of treatment, or other inflammatory markers which have been shown in at least systemic disorders like CRP or IL-10, 6, etc. Again, this is an open question, but I think would be important to come up with essentially like a clinical and lab-based risk calculator, if you will, that I think would kind of reassure providers even more than depending on these studies. But we're hopeful that this at least raises the awareness and moves the field forward in being able to get the patients the treatment that could be helpful for them.
Wonderful. I think we'll turn it over to the press now.
All right. Thank you very much, Dr. Rajarajan. Journalists, please post your name and news outlet in the Q&A if you would like to ask a question. We will then ask you to unmute yourself, and we will be able to hear you ask your question. Pauline Anderson of Medscape, if you would like to go ahead, unmute yourself, you can ask your question.
Oh, hi there. I'm wondering, I don't think I understand what immune checkpoint inhibitors actually are. What do they do? And also, you said that these findings are reassuring. I wanted you to expand a little bit more on your message, your sort of take-home message for doctors on this reassuring findings?
Yeah, thank you for that question. So basically, our body, our immune system has naturally these checkpoints that allow our body to tampen down immune cell activity, right? So this is using the setting of if something chronic inflammatory has been going on, you want to stop the inflammation from happening because that can have a lot of other downstream symptoms and increasing your risk for other conditions. And a lot of cancers can take advantage of this actually, because some of parts of our immune system can attack the cancer or the tumor itself. But by having these checkpoints in place or by stopping our immune cells from attacking the tumor that can then grow kind of unfettered, right? So what these medications do is then inhibit those checkpoints. So basically taking them out of the picture so then our immune cells can actually go and attack the tumor itself. And so that's the basic mechanism of that. It's kind of complicated in that it has multiple types of action and different kind of targets that it can go based on different cell types and whatnot. But that is the mechanism. And then why we say it's reassuring and how this would impact care is that, so the fact is that by taking off the brakes, if you will, of the immune system and letting it kind of go, attack the tumor, you have the increased risk, at least hypothetically, of letting the immune system also kind of derail and attack other parts of your body that's not anticipated or off that target. And this can lead to things like relapses of your pre-existing disease or other immunologic adverse events. And these whole span all the body systems. Right? It can be like skin disease, it can be muscle disease, heart disease. I just focused on the neurologic disease. But this understanding gave providers, especially early on, a lot of pause in that, giving a patient autoimmune disease and a drug that unlocks the immune system even further and letting it run possibly rampant seems scary, right, at face value. And so that's why, at least in this population of older patients without as much of an active MS disease profile, that is reassuring that they did not experience the high rates of relapses or other adverse events. So, and so we're saying that instead of being a blanket no for patients with MS, that they should not be getting this medication, or even kind of delaying the treatment a bit until it's the last option possible, to reassure providers to think about this earlier and to start it if needed, and that it's clinically indicated from the oncologic perspective. Because in our studies, we found that what is mostly harmful to the patient or leading to mortality or loss of function is actually the cancer itself and not the MS activity and not the neurologic side effects from the drug.
Thank you.
Welcome.
Thank you, Dr. Rajarajan. Seeing no more questions, I do want to tell journalists that if you do have questions, either now or after our press conference today, you can send those to us and we will make sure that Dr. Rajarajan gets a chance to answer your questions for you. Dr. Rajarajan, thank you for joining us today. We really appreciate your presentation as well. Dr. George, would you like to share some closing remarks?
Yeah, thank you. Yeah, I just want to thank all the researchers for taking the time to discuss the results, all the press for the great questions and discussion, and for to the AAN and the AAN staff for hosting us today. I think there's a lot of other great science coming up at the meeting here. So if you have further interest, please refer to the American Academy webpage or download the meeting app to find out all the other great science that will be at the meeting. And just want to look forward to seeing everyone there.
Thank you so much, Dr. George. We really appreciate you leading this press conference today. Journalists, if you have any other questions for the authors, email our AAN annual meeting press room team, Renee Tessman, myself, and Natalie Conrad at the email addresses that you see on your screen. You can also email media@aan.com. On behalf of the American Academy of Neurology, thank you, Dr. George, as well as Dr. Desai, Dr. Chu, and Dr. Rajarajan for sharing their research today. And thank you, journalists, for attending the AAN Annual Meeting Top Science Press Conference. For more information about the American Academy of Neurology and the 2024 AAN Annual Meeting, please visit AAN.com. Have a wonderful afternoon.